very much. Okay, we'll just get started. There's a lot of material to cover, so I'm going to try and go as quickly as I can, and hopefully we can get through most of it. So the learning objectives today are to discuss the approaches to screening and diagnosis for opioid use disorder. Number two, to describe how to select an OAT medication in collaboration with the client. And number three is to describe how to initiate an OAT medication in collaboration with the client. So it's important to approach conversations about substance use with a non-judgmental and trauma-informed perspective, to practice non-judgment in our conversations and approach the conversation and topic openly. We want to recognize that talking about substance use can be difficult for some individuals due to past experiences of stigma, discrimination, and trauma within and outside the healthcare system. Many people who use substances have some history of trauma. Applying trauma and violence-informed approaches at all times helps create a safe and supportive setting for all people. At the bottom, these two boxes talk about cultural safety and cultural humility. Cultural safety is an outcome wherein people feel safe and respected within an environment, and it recognizes and strives to address power imbalances, such as the client-clinician relationship that's embedded within the health system. Cultural humility is a lifelong process of self-reflection and self-critique, with a commitment to learning alongside others. So screening and consent, we can ask for the client's consent and provide context prior to asking screening questions to foster trust and comfort. We want to remind the clients of the limits of confidentiality, such as who on the care team can access client health records without client consent. You can start the conversation by saying something like, I routinely discuss substance use with all my clients. Would it be all right for us to talk about this now? We go into the next slide for screening. There is a 2-item screen of drug use. So clinicians can use a validated screening tool to screen for opioid use. There's a 2-item screen of drug use tool, and this is a simplified screening tool that can be used to screen for opioid use. It's developed and validated to identify substance use other than alcohol use in primary care settings. Clients are asked to estimate their drug use in the previous 12 months. The first question of the 2-item screen asks, how many days in the last 12 months have you used drugs other than alcohol? 6 or fewer days is a negative screen, and providers should proceed to the second question if the client answers 2 to 6 days. If it's 7 or more days, that's a positive screen, and the provider can conduct a diagnostic interview using the DSM-5 TR criteria. Now, moving on to that second question. The second question asks, how many days in the last 12 months have you used drugs more than you meant to? 2 days or fewer is a negative screen, and providers, again, can offer harm reduction education, supplies, referrals to clients who answer 1 to 2 days. 3 or more days is a positive screen, and again, here's where we would engage in a diagnostic interview with the DSM-5 TR. Clinicians should offer harm reduction education, supplies, or referrals to other support services to patients who respond to the screening questions with numbers greater than 1, but less than the positive screening criteria. So opioid use disorder and diagnosis. Opioid use disorder is a complex condition that involves a pattern of opioid use that negatively impacts a person's life and increases the risk of opioid-related harms. Clinicians can use the DSM-5 TR to recognize opioid use disorder in individuals who screen positive for opioid use. However, remember, not everyone who uses opioids has an opioid use disorder. Opioid use disorder is treatable with evidence-based interventions, and all adults who are diagnosed with opioid use disorder should be offered opioid agonist treatment, or OAT, as the standard of care. So we'll talk a little bit about how to become an OAT prescriber. There's a process in which, in order to prescribe all types of OATs to clients, physicians and nurse practitioners must complete a POAT SP course and a preceptorship. And registered nurses and registered psychiatric nurses may also become certified to prescribe OAT as well. Completing the POAT SP course alone does not enable you to prescribe OAT medications. You need to also do that preceptorship. MDs, NPs, and RNs and RPNs take 2 different POAT SP streams tailored to their role and complete different workbooks. The overall process of becoming a prescriber is the same for each stream. Clinicians complete the POAT SP course, then the workbook, and then an in-person preceptorship. That workbook, it contains case scenarios and questions to apply learnings from that POAT SP online course. MDs and NPs complete either the community or acute care book, and RNs and RPNs complete the RN-RPN workbook. The preceptorship is in-person education with an experienced prescriber. So there's an opportunity to apply your learnings from the POAT-SB course and the workbook in clinical practice. The workbook is reviewed by the preceptor. For discipline-specific information about the education and training pathways to prescribe OAT medications, see these links or the QR code on the screen here, and the link will also be in the resources at the end of the presentation. So becoming an OAT prescriber. Nurse practitioners and physicians can prescribe buprenorphine naloxone, also known as Suboxone, without any additional training. Nurse practitioners and physicians must complete the POAT-SP course and preceptorship to prescribe extended-release buprenorphine, also known as Sublocade, methadone, slow-release oral morphine, which is known as Cadian, and injectable OAT. Registered nurses and registered psychiatric nurses can become certified practice opioid use disorder to prescribe buprenorphine naloxone, Suboxone, Sublocade, methadone, and Cadian with the completion of the POAT-SP and preceptorship. So prescribers are required to complete the manufacturer-provided course prior to prescribing Sublocade, which is our extended-release buprenorphine. So next we'll be talking about selecting an OAT medication. So we want to think about things collaboratively, and there are several practice strategies to support collaboration and choice. The use of statements that make collaboration and choice explicit, you can say things like, it's important to have your feedback every step of the way. Inquire about others who might be able to help support the client, and it's important for the client to define how they would like other people to be involved in their care. For example, you can ask, would you like to involve any family members or friends in supporting your care? You can inquire about the client's priorities and hopes for treatment. An example can be, what is the most important thing for you to address in your care? You can explore and problem solve barriers. For an example is, are there any obstacles to your care that you can think of? What can I do to support you in overcoming those obstacles? We want to work through details with our clients, and an example can be asking somebody, do they have a preference as to what time of day or time to come in and see me? And you want to work in a feedback-informed way, and you can ask, like, could you tell me a little bit about how your care plan is working for you and how your support system is feeling about that? So there are some factors to consider for the selection of medication. Individual factors should be considered and help to inform the OAT selection with clients. The initial presentation, such as whether the person's in active withdrawal, their level of motivation to engage in treatment, and their overall well-being. You can review the contraindications and cautions for each OAT medication, which we will go a little bit into, but some of these could be if someone's currently taking a monoamines oxidase inhibitor or a MAO inhibitor within the last 14 days, if someone has chronic kidney disease, severe respiratory compromise. You also want to be able to check the product's monographs for the full list of cautions and contraindications. These are just a few examples. You can also think about drug-drug interactions. So you can ask the client what medications they are on and check the pharmanet before prescribing. Methadone has a higher potential for interactions with several medications, such as antibiotics, antidepressants, or antiretrovirals, as an example. Treatment preferences and goals are important. You can ask the client about their treatment and personal goals and any treatment preferences. For example, if they prefer to start their medication at home versus in the clinic. Lifestyle requirements. You can ask about lifestyle factors that may impact medication selection. For example, people living in remote locations who frequent travel may have a preference for medications that allow more flexibility with take-home dosing. Previous experience with OAT. Ask clients about if they have been on OAT before and what their experience was like for them, as well as what helped or hindered their experience. And this can really help providers get a clearer picture of what may work for a person and what may not, and how to help maximize their chances of success with a different OAT medication. So I'll talk a little bit about the opioid agonist treatment options that we have. The OAT options available and covered under Pharmacare in BC are number one, buprenorphine-based formulations, and you can split that into extended release buprenorphine, Sublocade, or buprenorphine naloxone, Suboxone. You also have the column here of methadone, and that comes in methadose or Methadol D. There is compounded methadone and methadone sugar-free, which can be covered under special authority approval for those who have trialed the regular benefit formulations without success. There's also slow-release oral morphine or Cadian. In the following 5 slides, we will discuss different aspects of the buprenorphine-based formulations, methadone, and slow-release oral morphine. that may be important considerations for clients when selecting an OAT medication, such as how long it takes to reach a maintenance dose, the potential for take-home doses, and the safety profiles. Although we are not discussing injectable OAT today, IOAT is an option for treating those with severe opioid use disorder who have not benefited from oral OAT, and the available medications would include hydromorphone or diacetyl morphine. So we'll start off talking a bit about buprenorphine naloxone or Suboxone. It's a 4-to-1 combined formula of buprenorphine to naloxone. Buprenorphine is a partial opioid agonist, which is an important piece to know about how it works. And then naloxone is an opioid antagonist to deter the injection and insufflation of tablets. Tablets are taken sublingually once daily during the maintenance. During the titration, you'll be taking it multiple times a day. And this can vary depending on which method you choose. Take-home doses are available immediately or can be available immediately, and induction can be completed with take-home doses as an option. Physicians and nurse practitioners can prescribe buprenorphine naloxone without completing the POAT-SP course and preceptorship. Moving on to extended-release buprenorphine, some might know this better as Sublocade. It's a monthly injection of buprenorphine, and it's administered via abdominal subcutaneous injections by a physician, a nurse practitioner, nurse, or pharmacist. Extended-release buprenorphine contains the same partial opioid agonist as buprenorphine naloxone, still buprenorphine, and it's the same medication, just in a different formulation. Take-home doses are not possible, as you have to administer it by a healthcare provider. And as a note, the FDA recently approved a label change for extended-release buprenorphine, including updated guidance on rapid induction and administration. However, Health Canada product monograph hasn't been updated to reflect those changes yet. And as such, the guidance in this presentation aligns with the Health Canada product monograph and the BCCSU's extended buprenorphine guidance. We'll talk a little bit about methadone. Methadone is a full opioid agonist, different than we were just talking about with buprenorphine. So it's a full opioid agonist and is taken as a once daily oral solution. It takes several weeks to reach a therapeutic dose. Take-home doses are possible once an individual has been stable on the medication for the minimum required time, and they demonstrate evidence of medication adherence. They can meet clinical and psychosocial stability criteria, such as the ability to keep an appointment and have minimal behavioral psychiatric issues at the point of assessment, and also no high risk or uncontrolled substance use patterns that cause frequent drug poisonings or blackouts or other severe safety risks. They start as non-consecutive if you're going to be working with carry, so non-consecutive, and then you would move into consecutive when an individual is stable for several weeks on non-consecutive doses. Talk a little bit about slow-release oral morphine, or also known as Cadian. Again, this is another full opioid agonist. It's administered once daily as an oral capsule. And that medication slowly releases over 24 hours. It takes about, it varies how long it takes to reach a therapeutic dose, but usually 1 week plus or more to reach a therapeutic dose, maybe 1, 2, 3 weeks. As with methadone, take-home doses are only possible when an individual has been stable on the medication for the minimum required time, and they demonstrate evidence of medication adherence, and again, meeting the clinical criteria for psychosocial stability. So we'll talk a little bit about the safety profiles. It's kind of a difficult chart to explain, and it's probably good to go back and look at this after the presentation, but I'll try and go through some points here. Both buprenorphine-based medications have milder side effect profiles, while methadone and Cadian have more frequent, severe, and dose-dependent side effects. Buprenorphine-based medications have fewer drug interactions, while methadone has the highest potential for adverse interactions. Slow-release oral morphine may have fewer drug-drug interactions than methadone. Both buprenorphine-based medications have a lower risk of drug poisoning due to buprenorphine's ceiling effect for respiratory depression. So the ceiling effect is after a certain dose, the effects of the opioids, which in this case we're talking about respiratory depression, are blocked with further dose increases. Methadone and Cadian have a higher risk of drug poisoning compared to buprenorphine. Methadone is associated with QT prolongation, while buprenorphine may be associated with QT prolongation, and slow-release oral morphine is not associated with QT prolongation. So you need more intensive monitoring for individuals with a pre-existing QT prolongation risk, such as those being prescribed other QT prolonging medications or family history of sudden cardiac death if you're going to prescribe methadone. Buprenorphine has a risk of precipitated withdrawal, particularly with our traditional inductions. The risk is decreased if you chose a low dose style induction. Precipitated withdrawal is a sudden worsening of withdrawal symptoms when a partial agonist, like buprenorphine, is given to a person who has full opioid agonists on board, such as fentanyl or other opioids. Extended release buprenorphine, methadone, and Cadian do not have the risk of precipitated withdrawal. Okay. There is more substantial evidence for the use of Suboxone and methadone compared to Cadian, and in the absence of client preference or other client-specific factors that would favor other medications, buprenorphine naloxone could be considered as the favorable OAT option due to its superior safety profile. So we'll talk a little bit now about initiation. You want to conduct and document a baseline assessment, including but not limited to the patient's physical and mental health, the clinical rationale for initiating OAT, review of their substance use history, exploring the treatment goals, choice, and rationale, and then ordering laboratory tests as indicated. So we'll talk a little bit about Suboxone here. We'll talk about the low dose induction in contrast to the traditional or take-home. So during a low dose induction, small doses of Suboxone are titrated while a full agonist opioid continues until a therapeutic dose of Suboxone is reached. It may be preferred to use this induction method for people currently using fentanyl or other intermediate or long-acting opioids. You can do this at home or you can do this in a clinic. It does not require abstinence from opioids or a period of withdrawal. And so a full opioid agonist, for example, Cadian or methadone, can be co-prescribed to reduce reliance on the unregulated drug supply during a low-dose induction. And mild to moderate withdrawal symptoms are not uncommon, and we try and manage that by slowing down the titration or providing adjunct medications such as dimenhydrinate or clonidine or ibuprofen. Here's an example of a low-dose induction. This is just an example, and so there are different variations on this, and different types of facilities have their own protocols. If you look closely, it has days 1 to 7 along the side there, so it takes about a week on average. And you can see here it starts with lower doses. So in this case, it goes from a dose of 0.5 all the way to 12 milligrams. And what changes is either the dose goes up or the number of times a day that you take the dose goes up. So on the first day, it's 0.5 milligram twice a day. On the second day, it's still 0.5 milligram, but 3 times a day. And you'll see the doses will increase or the frequency increases. It's to gradually and slowly get us to a higher titration while the patient can still tolerate the withdrawal symptoms. You can see on the side here, it says other opioid use. And so you can continue full use of a full agonist. So that could be Cadian, that could be methadone, where sometimes people continue to use fentanyl or other opioids at the same time as using the buprenorphine naloxone. Day 7, you'll see it changes there in the column, and that's when you can stop the other opioid and you can rapidly titrate your dose of Suboxone to a more adequate dose. Moving onwards, I'll talk about another way to start Suboxone, and that's called our traditional induction. During a traditional induction, the client takes a dose of Suboxone every 1 to 3 hours until their withdrawal symptoms are addressed or they reach the maximum dose for the day. A traditional induction may be appropriate for individuals who want to reach a therapeutic dose quickly. And it's also for someone who's already in or really close to a moderate level of withdrawal. You have to be abstinent, but are at risk of returning use. You can consider something like this. It can be initiated at home or in the clinic as well. And you can discuss the risk of precipitated withdrawal and management options with the client before starting a traditional induction. You can advise the client that precipitated withdrawal occurs within 30 or 60 minutes after the first dose if it's going to happen. And the client is starting a traditional induction at home. If that happens, then you can instruct them to call the clinic if they're feeling markedly worse after the first dose, and then you can guide them through the next steps of how to manage this. So For the traditional induction, individuals have to be absent from opioids for 12 to 72 hours, depending on the opioid. And when they reach a moderate level of withdrawal, which we can grade with the COWS, the clinical opiate withdrawal score, you usually want to see a withdrawal score of at least 12. That means someone's in enough withdrawal that it's probably safe to start the induction. The reason I say it's safe is because you want to prevent precipitated withdrawal. So if you're already in a state of withdrawal, it's usually a case where you'll probably end up feeling better rather than in more withdrawal if I gave you the medication. For short-acting opioids, you can see it's like 12 hours. So an example could be hydromorphone. Intermediate-acting opioids, you want to wait at least 24 hours. Typically, this is the timeline we wait for something like fentanyl, at least 24 hours since the last dose. Continuing on, the prescribers should consider the client's risk of precipitated withdrawal when selecting a starting dose of buprenorphine naloxone. So clients who are at a higher risk of precipitated withdrawal, you should start slower. You should start lower. You can start at maybe 1-2 milligram tablet. Clients who use fentanyl are usually at a higher risk of precipitated withdrawal compared to those who use shorter acting opioids due to the lipophilic nature and high potency of fentanyl. Clients who are at low risk of precipitated withdrawal can start with maybe 2 milligram tablets. So you start at 4 milligrams as the initial dose. So we'll talk a little bit about extended release buprenorphine, also known as Sublocade. So according to the Health Canada product monograph, clients should be stabilized for a minimum of 7 days of 8 to 24 milligrams of sublingual tablets of Suboxone. Rapid inductions may be conducted for clients if indicated. The FDA recently updated the extended release product monograph to remove the requirement of 7 days of stabilization of tablets. The updated US product monograph now suggests clients can be transitioned to extended release buprenorphine after a 4 milligram dose of Suboxone. Supplemental Suboxone can also be prescribed while patients are taking extended release, and you can prescribe that to those who experience breakthrough withdrawal symptoms and cravings. In terms of dosing for extended release buprenorphine, for the first month, you would prescribe a dose of 300 milligrams that acts as part of a loading dose. After 26 days at least, then you would administer the second dose. And so for clients who have been stabilized on less than 18 milligrams of Suboxone tablets, you can then prescribe the second dose as potentially 100 milligrams. For clients who've been stabilized long-term over 18 milligrams, you can then give them a second loading dose of 300 milligrams. However, I will make a note, like common practice amongst the teams that I work with, we usually just go with 2 300 milligram loading doses and then potentially continue that or drop to 100 milligrams depending. We'll talk a little bit about methadone. For the baseline assessment, you may want to consider ordering an ECG if indicated. Again, if there's factors that increase the risk of QT prolongation. Starting doses are between 5 and 40 milligrams. That would be on the high end to start. And it depends on someone's tolerance and risk of toxicity. And you would prescribe this as daily witnessed. Prescribers should see clients in person or virtually at least weekly to carefully monitor the treatment response. Clinical assessment is necessary before adjusting the dose, given the unique pharmacokinetic properties of methadone. And there's also individual variability, which takes several days to reach a steady state, and individual variability in absorption rates, metabolism, potency, and cross-tolerance with other opioids. So this is something that you want to titrate gradually and slowly. We'll talk a little bit about Cadian. Usual starting doses are in the range between like 50 and 300 milligrams. It depends on the tolerance and the risk of toxicity. And again, initially prescribed as a daily witness medication. Dose increases should be separated by at least 24 hours to avoid increased risk of sedation and respiratory depression. We'll talk a bit about stabilization. So after initiation, you want to continue to titrate the OAT medication following the protocols of the BCCSU's guideline for the clinical management of opioid use disorder until the client reaches a stable therapeutic dose, which can be defined as, well, stabilization is reached when several conditions are filled. And so one can be cravings are reduced or eliminated without causing excessive sedation or intolerable side effects. Withdrawal symptoms are controlled for more than 24 hours following the dose, or the client reports a general level of comfort that their treatment goals are being met. So in summary, screening and diagnosis should be trauma and violence informed. and culturally safe and humble. We want to offer OAT to all adults diagnosed with opioid use disorder. Medication selection should be guided by client-specific factors such as individual preferences and needs and safety considerations. And the initiation protocols depend upon the medication, take days to weeks to reach a maintenance dose. And I think the next slide here is our references. And I hope we have time for questions. I try to go as quickly as I could. It's a lot of materials. Thanks for listening.